who are not able to afford Dasatinib. So now clinicians across the country can prescribe Arbidan irrespective of the affordability and doesn't have the stress regarding the cost of the product. We have a unique drug support program wherein we are reaching to all the 100% of the patients. Now to commence the event, I would now request to call upon Dr. Mv Agarwal to further take up the proceedings. Thank you. Sir is president of Hematological, past president of Hematological Association of India, and he will be coming very soon now. So please bear with us for some time.
Mr.
Yeah.
We
Okay.
will put the Dr. Seema on play.
Okay. So I would request Dr. Seema to please take care of the further proceedings of the meeting. Please, madam.
Can you see my screen? Hello.
No, ma'am. We are
No,
not.
ma'am.
Just do the share screen.
Okay.
Yeah. Yeah, Dr. Mv Agarwal is here.
I am not able to come to that screen now.
No.
Yeah, now it is there.
It is there.
Yeah.
You can see the screen.
Yes, yes, very well. Just make it full screen, please.
Okay.
Yeah, that's good,
Is
ma'am.
it okay now?
Yes.
Yeah, it is
You are
very
able
well.
to see?
Yeah, sure.
Seema, I have been able to join now.
Yes, sir.
Can I just give my introductory things?
Ji, sir.
Can you see my slide now? Full screen?
Yes, sir.
Welcome.
Yes, sir. Yes, sir.
Okay.
Yes, sir.
So, welcome to all the audience and the panelists. Education cell of MHG is very pleased to conduct these meetings. These are weekly pre-lunch webinars. These are going to be conducted every Sunday from 11:30 a.m. onwards for 1.5 to 2 hours, covering the subjects in the field of hematology, hemato-oncology, and allied subjects. Basically, the current affairs and futuristic views. And all of you for sparing your Sunday morning. I would like to introduce the next week's activity. Of course, we are discussing the novel agents in hemato-oncology, and the faculty is Dr. Seema Bhatwadekar, transplant physician, Hemato-oncology Care Center at High Symposium on Venetoclax and the Garg. She's assistant professor, Department of Medical Oncology at GCRI Ahmedabad. Then we have Lieutenant Colonel Dr. Uday, who is professor, Department of Medicine and consultant hematologist and bone marrow transplant physician at Army Hospital R&R Delhi. We have Dr. Vikram Mathews, who is associate director, professor of hematology, the Department of Hematology, Christian Medical College, Vellore, and then myself. Next week, we have 2 webinars. One is on Saturday, 30th of May in the evening, 6:30 to 8:30, and that's on sickle cell disease advances. 2-hour session on sickle cell disease with international speaker, Dr. Julie Cantor. She's director for the Adult Sickle Cell Disease, the Comprehensive Sickle Cell Center, University of Alabama, Birmingham, Alabama, US. So don't miss this opportunity to listen to our international guest. Next day, that is this Sunday pre-lunch symposia on 31st of May, we have advances in ITP, once again supported by Adley. This meeting will be introduced by Dr. Mukesh Sanklecha, pediatrician, Bombay Hospital, Mumbai. And I will be moderating the symposium in which we have got 5 speakers. Dr. Deepak Bansal from PGI Chandigarh, Dr. Sanjeevan Sharma from Army Hospital, Lucknow, Dr. Mukul Agarwal from AIMS, Delhi, Lieutenant Colonel Dr. A.T.K. Rao. Now closing the sharing of screen and asking Seema to take over. Seema, you can share your screen.
Yes, sir. So can you see this slide, sir?
Yes. Just make it full screen.
Yeah. Is it okay now?
Yes.
So good morning all, and at the outset I am thankful to Dr. Mv Agarwal and MHG for inviting me to be a part of this webinar. So today I am going to talk on Ibrutinib, which is BTK inhibitor. BTK, as all of us know, is a signaling molecule in BCR activation pathway. Activation of BTK results into downstream signaling events which are responsible for the cell survival, proliferation, cell adhesion and migration All these activities are implicated in the pathogenesis of many low-grade lymphoproliferative disorder, including CLL, MCL, and MZL. Today, I am going to focus my talk on Ibrutinib and its safety and efficacy in CLL patient upfront and relapse refractory setting. It is available in capsule form, 140 milligram strength. Both original and generic forms are available in India. So the dose in CLL is 420 milligram daily. It primarily gets metabolized in liver by cytochrome P450, and hence its drug interactions are unavoidable. And one must keep in mind that all the patients who are taking concurrent strong inhibitors or inducer should be contraindicated to take Ibrutinib. For same reason, consumption of grapefruit and civil oranges are also contraindicated. Reduced dose of Ibrutinib to 140 milligram per day can be given if patient is consuming moderate inhibitors. So if you see the integrated safety analysis of patients with CLL from 2 Ibrutinib phase 3 trials, it shows that adverse events were primarily grade 1 to 2 and the dose adjustments were infrequent. And dose reduction and discontinuation rates generally decreases over the time with Ibrutinib in both, which has been documented in both clinical trials as well as real world data. The same was seen in infection. The majority of infections were grade 1 or 2. Upper respiratory tract infection, pneumonia, UTIs were the most common infection during Ibrutinib treatment, and more than grade 3 infection occurred more frequently early in the treatment. Like in first year of the treatment, the risk is highest, which goes down over a period of time. So what to do if any toxicity or adverse events happens? If you observe more than grade 3 non-hematological toxicity or more than grade 3 neutropenia or grade 4 hematological toxicity, then interrupt Ibrutinib and restart it only after resolution of the toxicity or adverse event. On restarting, if toxicity reoccurred, then decrease dose to 280. On third recurrence, decrease dose to 140, and on fourth recurrence, you have to discontinue Ibrutinib. So considering the fact that there is an increased risk of adverse events if patient has a comorbidities or concurrent medications, we must have, all of us must have a checklist before we start Ibrutinib. If patient has a history of ongoing poorly controlled bleeding or major life-threatening bleeding or ongoing anticoagulation that cannot be stopped even briefly, or patient is older than 75 years of age, having cardiac comorbidities or unexplained syncopal attack, then in that situation, even though it is not contraindicated, think twice before starting Ibrutinib, and if at all it has to be started, start with caution with close monitoring. If patient is on ongoing invasive fungal infection treatment or any impending or planned surgical procedure is there, then wait, complete it, and then start the Ibrutinib therapy. Checking of the liver function test and the concurrent medication list is must because it might alter the dose of the Ibrutinib. HBV status has to be documented prior to starting Ibrutinib because it can cause a reactivation of HBV. So now we will go quickly through the clinical trials with the single drug or combination in relapsed refractory and upfront CLL patients, which has made a significant change in progression-free survival and to some extent changed the natural history of the disease. So Jesunet was the first trial which enrolled the previously treated relapsed refractory patient, and it showed significant improvement in the median progression-free survival, 44 months in all higher risk population. If you do the sub-analysis of the higher risk population, the best response was seen with the 11 Q deletion, 60 months of median progression-free survival, with the lowest response rate in 17 deletion P, 17P, deletion 17P with TP53 mutation, TP53 mutation, and complex characteristics abnormality, where you see the progression-free survival of 40 months. IgHV mutation status did not alter the progression-free survival, and in unmutated as compared to CIT, it has shown a good response. If you see this graph, it shows that lower is the number of the prior line of therapies, better will be the progression-free survival in relapse refractory CLL patients. So to conclude, this Resonate 6 trials, which has published its 6-year follow-up report in 2019, confirms the long-term safety and efficacy of Ibrutinib in relapse refractory CLL patients. Overall response rate was 91%, with improved outcome in all risk groups. Hypertension was observed in 21% and AF in 12%, with discontinuation of Ibrutinib happened in 16% of patients. Moving ahead to Resonate 2 trial study, where the previously untreated patients were enrolled, which again shows a significant improvement in the progression-free survival, and the best results were in the 11q deletion with 79% progression-free survival at 60 months. As it was in previous study, IgHV mutational status did not alter the progression-free survival. This again confirms that long-term safety and efficacy of Ibrutinib in previously untreated CLL, and improved outcome in all risk groups except in 17P, because 17P patients were not included in this trial. Major side effects which were observed were major hemorrhage 11% and AF in 16%. 73% patients could continue Ibrutinib more than 3 years. That means 27% patient had to discontinue Ibrutinib even though there was a good efficacy. So this was a poster presented in this year ASH on Resonate and Resonate 2 extended follow-up data, and it shows again that if Ibrutinib is started in an earlier line, you have a best. So this extended data of combined Resonate and Resonate 2 confirms that use of single agent Ibrutinib in earlier lines of treatment results in better progression-free survival, overall survival, and overall response rate with sustained efficacy in the patients of CLL, including patients with the higher risk prognostic features. Only 6% of patients discontinued due to the progression of disease, and Ibrutinib was discontinued in 19% of patients due to adverse events. This is the 8-year follow-up. This is the longest follow-up data. The manuscript of this data was published online first on March 24, 2020. It has been peer-reviewed and accepted for publication, but have not yet edited. Quickly go through this data. It shows that 7-year follow-up shows excellent overall response in upfront as well as relapse refractory patients. If you see this graph, the 7-year progression-free survival in upfront is 83% versus 34% in relapse refractory. This is overall survival reflected well in overall survival also. If you see the number of lines treatment before the Ibrutinib, again it confirms that if it is Ibrutinib is used earlier, it has a better progression-free survival. Sub-analysis of cytogenic abnormality shows that the response is best with when the abnormality is 13q deletion, and the worst when abnormality is 17p deletion. So over conclusion, and then there was a safety profile which again shows that significant number of patients had adverse events, but these grade 3 adverse events generally declined over the period of time except palpitation which remained persistent, and these adverse event treatment adherence which has led to treatment discontinuation, the number were significant in both first as well as relapse refractory status. However, what they have found is most of these discontinuation were in the first year of the treatment. So the conclusion was that it is the longest follow-up to date, the single agent Ibrutinib or any BTK inhibitor data, which shows that there is a sustained disease control in both first line and relapsed refractory patients with acceptable tolerability. Means you have to monitor definitely adverse events, and they are manageable as time goes. On comparison of Ibrutinib with immunotherapy, this was a latest data which was published in ASH 2019, shows the extended follow-up data of Ibrutinib with rituximab versus FCR, and it shows Ibrutinib with rituximab has a superior progression-free survival compared to FCR. Less than 7% Ibrutinib treated patient progressed on therapy, 14% discontinued due to adverse events, and 7% discontinued due to increased baseline CIRS score. So next is this alliance trial which compared the Ibrutinib with rituximab versus BR, and it again shows that Ibrutinib and Ibrutinib with rituximab had a superior outcome compared to BR. But this trial also showed that addition of rituximab to Ibrutinib did not improve progression-free survival over the Ibrutinib alone. In Helios trial is on when you combine Ibrutinib with the bendamustine and rituximab. It shows there is no progression-free survival benefit on addition of Ibrutinib to addition of BR to Ibrutinib. Then coming to chemotherapy-free treatment options, like those patients who have comorbidities and not able to start chemotherapy but want to go for a chemo-free option, Ibrutinib with obinutuzumab was given, and this shows significant improvement in the Ibrutinib with obinutuzumab arm, with 79% PFS at 30 months. And if you see this slide is slight busy, but it shows that it works well in all clinical or genetically high risk patients. There were significant number of AEs also which were observed in this trial. So coming to NCCM guideline, based on all this significant improvement progression-free survival data, the NCCM guideline latest in 2019 recommends Ibrutinib as a first line of treatment for all patients, whether irrespective of whether patient is young or old, frail or fit, and whether patient has a higher genetic risk abnormality or not. So if you have a good oral treatment which gives a very good progression-free survival with manageable toxicity, why there is a need for further improvement in CLA. Further improvement is required because there are a lot of comorbidities and concurrent medications which increases the adverse events. And if you see the real world data, almost 40 to 50% patients, in spite of having good efficacy of this drug, need discontinuation. All those patients who tolerate drug very well, in those patients CR rates are low, and the most disadvantage is it has to be continued for indefinite duration of time with only control on disease and no cure. So there are so many clinical trials and research going on to find out the way with the intention to cure CLL with the fixed duration of treatment. So I have selected 2-3 fixed duration trials which are showing promising results, and first is this Captivate trial, in which Ibrutinib is combined with the venetoclax. First 3 months only Ibrutinib, followed by Ibrutinib with venetoclax for next 12 months. And it has shown almost reaching to 100% overall survival and progression-free survival uh, with with peripheral blood showing 75% of patients showing MRD negativity, and bone marrow showing 72% patient MRD negativity. So first time we are talking about the MRD negativity, and as we know that deeper is the response, more is the expected is the CR and the progression-free survival. So same with the same combination, MD Anderson has come out and with the it echoed the same results like Captivate trial. 75% of patients showed MRD negativity, and this is ongoing. In 2019, actual started, and here with Ibrutinib with venetoclax, they have added obinutuzumab with the hope that it will have a more deeper remission and more sustainable duration of progression-free survival of treatment. So with all these ongoing fixed duration trials, they with the promising results, there is a potential that these trials may change the standard of care in future, provided the same results are evident in follow-up trials. And this was in May 2020. I saw in Blood combination of the Ibrutinib with CD19 targeted CAR T cell therapy. There was a lot of work going on in CAR T cell therapy in relapsed refractory patients, but the incidence of CRS was very high when it is used alone. But in this pilot trial, what they have shown that 90 patients they have enrolled, they started Ibrutinib more than 2 weeks before leukapheresis and continued for more than 3 months after CAR T cell infusion. And it was tolerated well in all patients with low cytokine release syndrome severity. And they have shown overall response of 83% with MRD negativity, 61%. And the probable overall survival at 1 year predicted is 86% with PFS 59%. However, all these are in pipeline and need follow-up data to confirm their efficacy as well as safety. So, to conclude my talk, I would say robust data on Ibrutinib has shown sustained and durable response in treatment naive as well as pre-treated CLL. Outcome is better when it is used as an earlier line. Efficacy in high-risk CLL better when compared with CIT. Toxicity is limitation but manageable and needs close monitoring as it decreases over a period of time. Fixed duration combination with venetoclax plus minus obinutuzumab may change the treatment landscape of CLL. Thank you very much.
Thank you, Seema. That was wonderful view of Ibrutinib in CLL. Now we have the symposium. We'll be taking question answers at the end. So now we have the symposium on venetoclax, the master blaster. And to begin this, we have Dr. Akanksha Garg. She is going to speak on what is exactly venetoclax. For those who have joined late, let me introduce Dr. Akanksha Garg again. She's Assistant Professor, Department of Medical Oncology at the prestigious GCRI, Ahmedabad. Oh, Dr. Akanksha.
Thank you, sir. So are my slides visible?
Yes, slides are visible. They are full screen. Go ahead.
Okay. So first of all, I'd like to thank the Mumbai Hematology Group, especially Dr. Mv Agarwal sir, for giving me this grand opportunity. So for the symposium on venetoclax, I will be first talking about the drug itself. Not able to move the slide. So to begin with, first we need to understand what is the BCL2 family of proteins. So BCL2 stands for the B cell lymphoma 2 gene, where this particular family of genes, it encodes for certain pro-apoptotic and anti-apoptotic genes, and their role is mainly for regulation of the cellular survival and inhibition of pro-apoptotic proteins. And they are mainly implicated in causing diseases such as the hematological cancers like CLL, AML, and multiple myeloma, as well as solid tumors like breast, prostatic, and lung cancer. They are also implicated in causing autoimmune disorders like type 1 diabetes mellitus, as well as schizophrenia. So BCL2, the tail actually spans over a period of 30 years, as this has been shown beautifully by this article by Dr. Francesca Pentimeli. And first, in 1984, this particular chromosome breakpoint within the translocation 1418 was discovered in follicular lymphoma. And then it was later found that it was actually the BCL2 which was involved in the human follicular lymphoma. Then in 1991, it was shown that BCL2 also contributes to autoimmune disease. Then in 97, the role of BCL2 in prevention of apoptosis was also discovered. Finally, in 2008, navitoclax was discovered as a potent oral bioavailable BCL2 inhibitor. And then in 2013, venetoclax, which is a selective BCL2 inhibitor, was discovered. And finally, in 2016, this particular drug was finally approved by the FDA for the treatment of CLL with 17p deletion, and also subsequently for AML in 2018. So this is the Walter Eliza Hall Institute of Medical Research, which is in Melbourne, Australia. And it was here where this group of gentlemen, headed by Dr. Andrew Roberts, actually discovered the drug. And it was indeed a triumph for science and translation. They won the Prime Minister's Innovation Award also for the same in 2018. So this is a slide showing the structure of the venetoclax, which is also known as ABT199. It is a compound which has a low aqueous solubility. So what is the mechanism of action of venetoclax? So as you can see here, in cancer cells, there is actually BCL2 overexpression, which allows the cancer cells to avoid apoptosis by sequestering the pro-apoptotic proteins, such as BIM and BAX. However, when the patient is administered venetoclax, this drug actually binds to the BHC domain of the BCL2, and it causes the freeing of the pro-apoptotic proteins, which then initiate the apoptosis by activation of cytochrome C caspases, and this ultimately leads to the cancer cell death. So this is just a slide to show the various strengths of the venetoclax available. It is available in the form of 10 milligram tablets. Here you can see they are round tablets and they have V written on one side of the tablet. Other strengths are 50 mg and 100 milligram. The 50 mg and 100 milligram tablets are oblong in shape. Here you can see that these are the blister packs for the Venclexta or the original venetoclax, which are labeled according to the weeks of the ramp-up schedule, which I will be discussing subsequently. So they are labeled as week 1, week 2, week 3, and week 4, and so on. They basically comprise of colloidal silicon dioxide, which are anti-caking and stabilizing agents, as well as certain coloring agents like iron oxide yellow, iron oxide red, and so on. So these are just a slide to show the various brands which are available in India. The original one is Venclexta and Venclexto, which are both produced by the company AbbVie, which is the original brand. And this is the Lucivenet brand, which is available in India. This is the X100 brand, which is the Bangladeshi version. As far as the pharmacokinetics go, absorption of the drug is mainly in the intestine, and it needs to be taken with a high-fat meal. As I had discussed earlier, the drug has a low aqueous solubility, hence it is well absorbed with a fatty meal. It is highly plasma protein bound, and the T half is 26 hours. The metabolism is predominantly hepatic, and the main metabolite is M27. The excretion of the drug is mainly through the fecal route. So coming on to the medical uses, the label indications for the use of venetoclax is CLL, specifically in the deletion 17p group. In acute myeloid leukemia, it is used in combination with HMAs or the hypomethylating agents, as well as low-dose cytosol. Specifically in patients who are above 75 years of age, or those patients who are not suitable for intensive chemotherapy or have comorbidities. Off-label use has been seen in relapsed refractory DLBCL as well as mantle cell lymphoma. In multiple myeloma, specifically in translocation 11-14 patients, as well as also in primary AL amyloidosis where this particular translocation is present. In pediatric patients, the use has been seen in certain ongoing trials in AML, NHL and neuroblastoma. And many researchers have also used this drug as a post-transplant maintenance therapy. So what are the baseline investigations that one needs to see? It is important to elicit the drug intake history to see for any possible drug interactions with the drug, renal disease, history of gout and vaccination. We need to do a baseline CBC with differential count, serum electrolytes, RFT and LFT, UPT in case of females before starting therapy, and it is also essential to monitor tumor lysis parameters, which I will be discussing. So coming on to the dosage ramp-up schedule in CLL. So initially when the trials began, this was the design of the ramp-up schedule over a period of 3 weeks. So the patient was started on lower doses such as 20 milligram or 50 milligram, and the step-up doses were increased to a maximum dose of almost 1200. However, this was not a very popular method because it led to very high incidences of tumor lysis syndrome. Hence, the expanded safety cohort study was done where the ramp-up schedule looked something like this. So in week 1, you started with 20 milligram and then gradually increased to 50 milligram, 100 milligram and so on till week 5 where the dose was increased to 400 milligram. In AML, a similar dose ramp-up schedule is used. However, this is done daily, starting from a dose of 100 milligram on day 1 and increasing from 200 milligram to finally 400 milligram or 600 milligram, depending on whether you are using it in combination with the hypomethylating agents or if you are using in combination with low-dose cytosol. In myeloma, as you can see here, this is a study done by Dr. Shaji Kumar and his team. Here, the efficacy of venetoclax as a targeted therapy for relapsed refractory multiple myeloma, specifically for the translocation 11-14 was done. And here they saw that in the safety expansion cohort, the ramp-up was done up till a dose of 1200 milligram. And this was done over a period of 2 to 3 weeks. But what are the instructions that you need to give to the patient before you administer the drug? So it is important to take the medication whole with meal and water and at approximately same time each day. You should not be chewing or crushing the drug. You need to increase the water intake to almost 6 to 8 glasses of water per day, starting 2 days before, on the day of the first dose, and each time the dose is increased. The drug needs to be stored at 30 degrees Celsius, and any fever or infection needs to be promptly reported to the treating physician. The patients should avoid live vaccines along with venetoclax. What if the dose is missed? So if it is missed within 8 hours of the daily schedule, then you need to take the dose as soon as possible and resume the normal daily dosing. However, if the missed dose is more than 8 hours from the daily schedule, then you take the dose the next day and avoid the same day's dose. And if the patient wants, additional dose needs to be taken for that particular day. Drug interactions are also very important. specifically the CYP3A inhibitors like posaconazole, protease inhibitors, calcium channel blockers, ciprofloxacin, and dose needs to be adjusted as shown here in the table. And it is advised that if you need to give these drugs along with the venetoclax, then a gap of at least 6 hours should be maintained. Side effects are also important. Face hematopoietic side effects including neutropenia, thrombocytopenia, and anemia. GI disturbances are seen, such as diarrhea, nausea, and vomiting. A lot of patients also experience constitutional symptoms like fatigue, constipation, peripheral edema. Pulmonary side effects including pneumonia, cough, and URTI are also seen. And some patients also suffer from back pain, headache, hypokalemia. But most important is the side effect of tumor lysis syndrome. And as per the NCCM guidelines, specifically in CLL and SLL patients, the tumor lysis syndrome is divided into 3 risk categories: low, medium, and high, according to what is the size of the lymph nodes or the absolute lymphocyte count. And accordingly, the measures are advised, including oral hydration, use of febuxostat, IV hydration, or raspberries. For patients who have a creatinine clearance of less than 80 ml per minute, ideally you should be hospitalizing the patients. It is important to monitor the blood chemistry, specifically at time points such as prior to giving the dose, then at 6 to 8 hours, post the first dose, then at 24 hours, and so on. Toxicity needs to be managed very judiciously, specifically for tumor lysis syndrome. For any occurrence of this event, you need to hold the next day's dose, and if the blood chemistry resolves within 24 to 48 hours, then you can resume at the same dose. However, if the changes require more than 48 hours to resolve, then you need to resume at a reduced dose. For grade 3 and 4 non-hematologic toxicities, for the first occurrence, you need to interrupt the dose, and once the toxicity has resolved to grade 1 or baseline, the therapy can be resumed at the same dose. For second and subsequent occurrences, then you need to follow the dose reduction guidelines. For hematologic toxicity, for the first occurrence, you need to interrupt the dose, and GCSF and empirical antibiotics may be advised accordingly. If the toxicity resolves to grade 1 or baseline level, then the therapy needs to be resumed at the same dose. However, for second and subsequent occurrences, you need to interrupt the dose and follow the dose reduction guidelines. And if the patient requires dose reductions to less than 100 milligram for more than 2 weeks, then consider discontinuing the drug. So this is the table where you can see the dose adjustments according to the dose at which the therapy has been interrupted. The restart doses are advised. In patients of AML, majority suffer from hematologic toxicity, mainly the grade 3 and grade 4 hematologic toxicities, and the occurrence depends on whether you have achieved prior remission or not, and you need to give the patient empirical antibiotics, GCSF, and give supportive blood transfusion products. And actually in this particular flow chart, you can see that if the patient has developed an ANC of less than 500 or a platelet count of less than 25,000 after the first cycle of venetoclax, then you need to see the day 28 bone marrow aspiration. So if the patient has a persistent disease on day 28 marrow, you need to start the next cycle without any delay or dose modification. And if the marrow is in remission, then you hold the venetoclax and delay the next cycle. And if the blood count recovery occurs within 1 week, then you can start the next cycle without any dose modifications. However, if the blood count recovery takes more than 1 week, then you need to reduce the duration of the venetoclax from a 28-day cycle to 21 days per cycle. For any subsequent cytopenias, recurrent cytopenias, again, the marrow picture is extremely important because you need to rule out an AML relapse, and if such event occurs, then you need to consider alternative treatment. And if the marrow is in remission, but if it is hypocellular, you may need to reduce the dose of your hypomethylating agents. Certain populations, such as patients with hepatic impairment, venetoclax toxicity can be seen, especially in patients with the Child-Pugh C classification. In impairment, no clinically significant impact of the drug is seen. In patients, according to age, gender, ethnicity, and weight, there is no effect on the dose. And in patients who are pregnant and are breastfeeding, the dose of venetoclax is contraindicated. Just a slide to show what are the pricing schemes for the various varieties which are available in India. As you can see here, the original Venclexta brand is the most expensive, standing at rupees 5.5 lakhs for a bottle of 120 tablets. The Venclexto is slightly cheaper at rupees 50,000 for 112 tablets. And the cheapest version is that of the Bangladeshi version, which is the Venex 100, which is costing at approximately rupees 23,000 for 30 tablets. So for 120 tablets, the cost would be around 75,000. So to conclude, venetoclax is an orally highly selective BCL2 inhibitor. It is a promising new therapy for CLL, AML, and multiple myeloma, and its activity is very promising in combinations. It is also being studied for a variety of pediatric diseases like AML, NHL, and many trials are ongoing. PLS is an important side effect which needs to be managed very judiciously, and many generics are available at lower prices, and hence more and more patients can use this wonderful drug. So these are my references, and I thank you all for your kind attention.
Thank you so much, Dr. Akanksha. That was a wonderful review of how to handle this complex compound.
Thank you, sir.
Thank you. We move on to the second speaker, and that's Lieutenant Colonel Uday. Again, for those who have joined late, Dr. Uday is Professor, Department of Medicine. He's consultant hematologist and bone marrow transplant physician at Army Hospital Research and Referral in Delhi. And his subject is now to talk about specifically venetoclax in chronic lymphocytic leukemia. Over to Uday.
Firstly, I would like to thank Dr. Mv Agarwal, sir, my teacher, for giving this opportunity. Are you able to see the slides, please?
Yes.
Yes, we can see.
So, sir has given me the responsibility of talking about venetoclax in CLL. So, over the next 15 minutes, I'll be quickly winding up what is the current day role of venetoclax in CLL and how do we look at the future. So, to introduce, I would not like to repeat most of the things which have already been excellently covered by Dr. Akanksha in the previous slides, but just to say that in the last 5 years, starting from accelerated approval to approval for even first-line therapy by May 2019. So the drug in 4 years has spanned to first-line therapy in CLL. And as Dr. Akanksha said, it's a second-generation BCL2 inhibitor, the first generation being navitoclax, which used to inhibit both BCL-XL as well as BCL2, whereas the venetoclax only inhibits BCL2. So the unnecessary adverse events are taken care of, particularly the thrombocytopenia part of it. Now, among all the important pharmacokinetic features, the metabolism in liver by CYP3A4 is an important aspect for venetoclax because that would dictate dose modifications with certain other co-medications that we routinely prescribe. And the antifungal prophylaxis by either posaconazole or voriconazole would warrant a decrease in dose of venetoclax by around 30 to 50% of the dosages. Now, in Indian scenario, this particular feature can be used actually to cut down on the prices, though we need to study it in a long term, in a prospective manner to see whether that would really help the patients by cutting down the dose by using concomitant azoles. Now, special situations, as has already, we need to decrease it by 50% reduction, whereas as you see for the rest, there is no renal modification. It's contraindicated in pregnancy and breastfeeding. In geriatric patients, please use the cumulative illness score, the CIRS, for dictating the dose. And it does not require a change in dosages for the obese patients. Now, the dosing has already been described, but I would like to add up 1 or 2 points. One size doesn't fit all. So, you need to actually go to what type of regimen are we prescribing. So, if it is a single agent venetoclax, the dosing schedule would be different. When we are going to combine it with other drugs, the dosing schedule would be different. As you would see on the right side panel, in patients when we give it venetoclax with obinutuzumab, we don't start the treatment upfront on day 1, whereas we shift it to day 22. Whereas when we combine it with rituximab, we start it from day 1 onwards. Whereas when we give it with ibrutinib, we give it from day 28 onwards. So it changes depending upon what combination are we using. Now coming to the timeline on CLL therapy and where did the venetoclax come in and fit into this timeline. So if you look in 2015, the observation for the patients who didn't have an active disease as per the IWG CLL guidelines, followed by that, based on the age and comorbidity, people used to prescribe chemoimmunotherapy by FCR more than bendamustine rituximab, and followed by a BTK inhibitor or PI3K inhibitor in combination with CD20 inhibitors. But if you compare the same on today's date, though the observation remains static, but the FCR and the BR have actually shrunken into overlapping thing. Many people now even prefer BR over FCR, particularly because of the less side effect profile and the less toxicity. And in fact, I kept the FCR circle slightly ahead for the sake of the teachers who have been practicing FCR for a very long time. But the point to note is both the BTK inhibitors and BCL2 inhibitors have come up in the front line. If you compare it with the small cartoon on the right side upper corner, so they are no more the therapies for a sequential therapy after the chemoimmunotherapy, whereas you can start prescribing both ibrutinib as well as venetoclax in the upfront scenario in combination with any of the CD20 inhibitors. Now, what has changed as far as the perspective of treating CLL is concerned? So now most of the physicians desire that we should not have too much of a myelosuppression or infections. They don't want a long-term marrow damage, or they want to avoid a secondary malignancy risk as generally seen with the chemoimmunotherapy. Most of us prefer targeted therapy over chemoimmunotherapy because of the oral treatment, less hospital admissions, and particularly in the West owing to the insurance problems for in-hospital versus OPD patients. Also, most of these drugs, that is the ibrutinib and as well as the venetoclax, they give you prolonged CR or increased progression-free survival when compared to chemoimmunotherapy or chlorambucil. And nowadays, we talk of achieving MRD in most of the diseases and as well in CLL as well. So, no more a complete remission or partial remission is an endpoint, and most of us want to achieve a MRD to achieve in the future a longer treatment-free remission. So achieving MRD is possible with venetoclax, which is not possible with ibrutinib or with chemoimmunotherapy. And most of us look at definitive duration of therapy when compared to a continuous therapy as seen with oral ibrutinib. So with these things in mind, the things have changed. These are the various places where the targeted therapy acts. If you see the venetoclax, it acts at the BCL2, the ibrutinib at BTK, and Lysis at PI3. What I want to basically bring out is they are all independent actions. So a combination, a permutation combination of these drugs might act rather than a monotherapy per se to lead to an overall greater benefit. But keeping in view the toxicity profile, which might also add up from one drug to another. Now, if we compare the three targeted therapies, that is ibrutinib, acalibrutinib, and the venetoclax on today's date, the pros and cons. The ibrutinib has the longest follow-up studies which are available. So we know more about ibrutinib when compared to the other two agents. But the cons are basically we have got indefinite duration of therapy. It leads to low complete remissions and low MRD, and it has side effects of atrial fibrillation and bleeding. Whereas acalibrutinib, the advantage is it has a reduced off-target effects as seen in ibrutinib, but the false side of it is we don't have a longer follow-up. It has to be given for indefinite duration, and as in ibrutinib, it does not lead to a higher proportion of CR or MRD. Lastly, coming to venetoclax in combination with Gazyva. So the advantage is it can be given only for limited duration. It leads to very high CR rates and MRD rates. But the false side of it is we do not have long-term studies. The tumor lysis syndrome, as was mentioned by the previous speaker, is a major problem, and IV administration of obinutuzumab would require still some amount of daycare / in-hospital observation. Now, if you look at this screen, this I pulled it out of a Blood article, How I Treat article, which was published around a month back. Very surprisingly, I find that in either TP53 mutated or intact patients, you see that ibrutinib with or without CD20 inhibitors being seen as the first line therapy in all groups of patients, whereas the chemoimmunotherapy has been restricted only to those patients who are younger, fit, who have a mutated IGHV and an intact TP53. So this shows how the world has been changing as far as treating CLL is concerned, though I might not fully agree with the author's choice and the preference, but I just brought this out to say how the guidelines and the things are changing over a period of time. Now you have to understand that improved PFS but not overall survival is seen with most of the targeted therapies, and all these studies have taken PFS as a surrogate for overall survival. But there are no studies to clearly prove that we can use PFS as a surrogate for overall survival. So when you read all these articles or these guidelines, you have to bear this in your mind. Now, when we look at the previously treated, that was for the first line therapy, and now this is for the relapse refractory setting. Again, you could see that venetoclax features in almost all the groups wherever the patient had been exposed previously to BTK inhibitors or not to BTK inhibitors, or to chemotherapy or not to chemoimmunotherapy. So, this is how the previously treated patients are being managed in the West on today's date. Now, if in India, if I have to say what I should be taking into consideration for choosing first line therapy, the essential considerations that I should have is what is the age of the patient, what are the comorbidities, what is the TP53 status, and what is the IGHV mutation status, which are absolutely mandatory to record before starting any therapy. The additional considerations of cardiac history and status, because Ibrutinib is associated with atrial fibrillations and cardiac comorbidity. Concomitant medications, because both Ibrutinib and venetoclax lead to CYP3A4 induced metabolism. Renal functions for Ibrutinib and for chemoimmunotherapy. The bulk of CLL for venetoclax, because it leads to tumor lysis syndrome when the bulk is high. And most importantly, the financial status and the logistic access to the different forms of therapy. Also, other than these patient-directed factors, the doctor or the physician who is treating need to have few goals in his mind. Are we looking for a fixed duration therapy or a continue looking at achieving deep remissions or prolonged treatment-free remissions? How much is the exposure time I am looking for? What is the potential for toxicities and how can I reduce it? And what about the long-term compliance of the patients? Because if I start prescribing Ibrutinib for a 40-year-old guy for the rest of his life, will he be able to take it or not? So these things needs to be taken into consideration before we choose the first line therapy. So the major advantages of venetoclax versus any other therapy is a fixed duration of the treatment and the advantages of having higher rates of MRD or CR when compared to any other drug on today's date. So if we look at, these are the various studies which have been published on venetoclax till date. If you look at the top few, the top 4, these are the ones which were actually when the venetoclax was used as a continuous therapy and mostly in relapse refractory setting. This led to the approvals of it, but you can actually discount most of the studies because they are all phase 1 or phase 2 studies. But if you look at the phase 3 studies, so the Murano, CLL4 and the MD Anderson studies are the one major landmark studies which I am going to describe in detail. Now, the first landmark study, that is CLL14 study in untreated CLL. So, in patients who have never received any form of therapy, but who had multiple comorbidities, as seen by CRIS score of more than 6 and a creatinine clearance of less than 70, the patients were given either venetoclax with obinutuzumab or chlorambucil with obinutuzumab for a total of 28-day cycle for venetoclax 12 cycles and obinutuzumab for 6 cycles. The primary endpoint was PFS as assessed by the investigator, and there were multiple other secondary endpoints. So if you look at the primary endpoint, there was a definitive difference between venetoclax versus chlorambucil when combined with a common CD20 inhibitor. But the point which needs to be noted is the difference started occurring only after the first 1 year. So any patient who is being started on venetoclax, don't expect differences when compared to the previous chemoimmunotherapies upfront. You would see them in long term, but not in the immediate near future. By comparing it with the IGHV mutation status and TP53, definitely venetoclax had a better survival both in TP53 mutations as well as in IGHV unmutated patients. And if you look at the responses, So the overall survival was not different as I was previously mentioning. Only there was a PFS difference and a difference in the CR versus PR rates in both the groups. And if you look at the Mrd negativity, so the UMRD that we commonly called as is undetectable MRD, wherein we look for one cell out of 10,000. So we say that it is 10 to the power of -4 sensitivity, either in blood or in bone marrow. So if you look at that, so that was statistically significant in venetoclax versus chlorambucil. And when you looked at 10 to the power of -6, it was also seen in much higher patients when compared to 42 versus 7. Now coming to the safety, if you look at the neutropenia and the total adverse event, grade 5 adverse events, they were higher when compared to the chlorambucil, but only statistically significant difference was the metabolism of the nutrition disorders, and there was no difference statistically in any other grade 3, 4 or 5 adverse events. So this was as far as the venetoclax in the upfront patients where we are giving it as a first line of therapy. The summary would be to say that these are those patients who have multiple comorbidities, have very high median age, and still it was found to be beneficial. Now, if you look at the venetoclax in the previously treated CLL patients, that is the Murano study. So, in this, the venetoclax with rituximab was compared with bendamustine with rituximab, and you could see a wide apart graphs of VR versus BR, and the venetoclax rituximab had higher PFS as well as overall survival, but the OS was not statistically significant. If you look at the safety profile, the neutropenia was much higher in patients with venetoclax versus bendamustine, but the febrile neutropenias were higher in BR when compared to venetoclax. So most of these neutropenias which were seen with venetoclax did not actually require in-hospital therapy or observations for febrile neutropenia, and they were actually could be managed just with GCSF supplementation, as was told by the previous speaker. Now, if I have to compare, on today's date, the favorite girl in the market as far as CLL therapy is concerned is Ibrutinib. And if I want to compare my product, which I'm talking today of Venclexta versus the proven product Ibrutinib, so it's like comparing Katrina Kaif with Anushka Sharma. Now, sorry for these online meetings, I can't see the saliva drooling out of the mouths of the audiences, but still, if I have to compare these two heroines, so the BCR inhibitor Ibrutinib has a better effect on the nodal disease, whereas venetoclax has a better effect on the blood or the marrow disease. The lymphocytosis would be seen secondary to Ibrutinib as a side effect, and previously there used to be a terminology known as PR with lymphocytosis whenever the Ibrutinib was launched initially. And if you look in relapse refractory setting, the patients who achieved CR was very high with venetoclax when compared to Ibrutinib. And the adverse event profile, we have already discussed the comparison between the two. Now, generally, we are taught that we should never compare two different studies because the study populated, but just for the sake of it, if I have to see, a median age between both of them was common. And if you look at these red lines, the 3-year progression-free survival was 82% in both the groups. But the point to be noted is that these patients in CLL14 had a much poorer profile when compared to Resonate study. So this is the comparison of venetoclax versus Ibrutinib, which I have already covered in the previous slides. Now, why should we compare? Can we not combine both? So it's like Yash Chopra film wherein you bring both the heroines together. And in this film, Nitin Jain from MD Anderson was the Yash Chopra, and he brought in a study wherein he combined Ibrutinib with venetoclax and published last year in Nccm. And you would see that if after 3 cycles of Ibrutinib, the number of patients who are achieving complete remission as seen with dark blue was very minuscule. Whereas after 18 cycles of venetoclax with Ibrutinib, the number of patients who had achieved CR or who have achieved the MRD is much higher. So there is a role, might be a role of combining Ibrutinib with venetoclax, but the audience have to understand that the toxicity profile also gets added, and so the patients might actually have a more toxic profile and more things to look at. Now I'll quickly cover 3 special issues with venetoclax. TLS has already been covered by Dr. Akanksha. So I'll just talk about the mitigation. When we are talking of combining with Gazyva, so never start the Venclexta up front. Give Gazyva in the beginning because it decreases the lymphocytosis, so it decreases the blood and the bone marrow load, so the chances of TLS decreases. Secondly, don't do the CT scan, staging CT scan upfront. Do it at day 22 or at the start of the cycle 2, because you can exactly know how much nodal disease is remnant in the particular patient. So you can assess the TLS risk better when compared to doing a staging CT scan upfront. And you can admit the patient not for the cycle 1 but might be for the cycle 2 during the ramp up phase for mitigating the TLS. Now, the second issue is venetoclax-induced neutropenia. This was also partly covered by the previous speaker. So what I would just say is give GCSF intermittently to make sure that you do not decrease the dose in the first 3 months of the therapy. Because the rationale for not decreasing the dose of venetoclax is CLL or any indolent lymphoma has a high burden of disease in the bone marrow. So by maintaining the venetoclax dose at 400 mg, there is a chance of clearing the marrow and a better recovery of count and a better progression-free survival. But if the patient has a recurrent neutropenia for more than 3 to 4 months, then you can look at drug-drug interactions or look at highest tolerated dose of venetoclax along with GCSF. Now, lastly, the resistance to targeted therapy. Now, Ibrutinib can have resistance in these 3 particular fashions, and you can use BTK inhibitors in all 3. Lysis can have in these 3 fashions, MYC amplification, PI3 amplification, and unknown patterns. So you can again use the venetoclax both in type 1 and type 2 resistance. But if I look at venetoclax in relapse on Ibrutinib, which is the commonest thing which is happening on day-to-day practice in the West currently, so preferably add a CD20 inhibitor and don't give single-agent venetoclax. Now, obinutuzumab has not been approved for relapse refractory setting, so rituximab remains the therapy. The median PFS for relapse refractory deletion 17p CLL with venetoclax was 24 months. So if you add rituximab, it can be much higher. Please continue Ibrutinib along with venetoclax, even if you are looking at Ibrutinib resistance, because whenever you withdraw a BTK inhibitor in patients who are on long-term therapy, there is a chance of CLL disease flare. So the BTK discontinuation should only be done after venetoclax has been given for 1 to 2 months or after the ramp up. The TLS risk assessment should be done by staging CT scan and mitigation strategies as told previously, and prolong the venetoclax beyond the fixed duration of 24 cycles if the patient has got TP53 mutation or has not achieved MRD positivity after 24 courses of venetoclax. Now, venetoclax is not a God's own product. It can also have resistance, and in case of resistance, there is an option of using idelalisib or CDK9 inhibitors or Ibrutinib if not used previously. So, this is your condition after listening to venetoclax for the last 2 symposia. So, if I want to say my interpretation in one slide of how I would take it, I will place venetoclax with confidence in CLL whenever the patient has a TP53 mutation or an unmutated IGHV, or if the patient has multiple comorbidities, and particularly if I am keen on giving fixed duration therapy and not lifelong therapy. Patients relapsed on BTK inhibitors, this definitely remains to be the drug of choice. Venetoclax in India, still chemoimmunotherapy remains the gold standard at many places because of the financial reasons, fixed duration, and experience of our dear oldies. Now, changing scenario to new gold standard Ibrutinib, particularly with the advent of generic Ibrutinib now, which is available in the market. So, Ibrutinib can be given if you are taking the finances into account. Venetoclax has to compete the prices with the generic Ibrutinib in the market for it to see the light of the day. The cost also gets compounded by additional costs of obinutuzumab, hospitalizations, and the serious adverse events. So we need to bear that in mind. So venetoclax certainly is the future in both upfront as well as relapsed refractory setting if economically viable. And nowadays, no presentation is complete without COVID, and that too particularly when a talk is being organized by Mumbai Hemato-oncology group, the epicenter of COVID in India. So I will choose Ibrutinib over any other agent because of the least chances of toxicity and the neutropenia when compared to any other drug for CLL on today's date. Not only for that, but we have a publication this week, around 2 days back, wherein there is a study on around 10 patients of BTK inhibitor Ibrutinib, which may protect against pulmonary injury in COVID-19, and they have presented data of 8 patients out of this 10, and they say that BTK inhibitors actually protected the patients in COVID, severe COVID patients. So, Ibrutinib might stand over venetoclax if the COVID has to continue for the next few months to go. So, I thank everyone for a patient hearing, and these are my disclosures. Thank you.
Thank you, Uday. That was fantastic. Now I invite Dr. Vikram Mathews, Associate Director, Professor of Hematology Department of Hematology at CMC Vellore, and he's going to tell us about venetoclax in acute myeloblastic leukemia.
Oh, sir, can you hear me and can you see my slides?
Yes, we can hear you. We cannot yet see your slides. Now we can, now we can see your slides.
Okay. Good afternoon, everybody, and I want to thank Dr. Mv Agarwal for inviting me to give this talk. I'd also like to thank the people who spoke before me, Dr. Akansha and Dr. Uday, for doing a great job in covering all the basics, so I don't have to go through it. And for the audience out there, I think venetoclax story in AML is still a little less complicated and hopefully should be less data and easier to walk through. So I thought before I go into venetoclax, I'm going to take a little step backwards and I'm going to try and address some of these issues. I'm going to talk about venetoclax in the context of current risk stratification, the major changes that are happening in AML, which are fairly radical, the biology and role of mitokines, that are agents that target the mitochondria just like venetoclax, the available data with venetoclax in AML, and talk about some practical strategies when we apply venetoclax in AML therapy, and talk about the need for region-specific data. So I feel we need to talk about venetoclax in the context of all this, and especially in the context of our own population. So when we talk about AML and risk stratification, there's a danger that people tend to jump to next-gen sequencing and molecular. And I think it's important to step back and say that age and performance score are the most important risk stratification parameters which have consistently held up on multivariate analysis. And I'm going to go back to a very old data set. This is the SWOG data of 2006, looking at age on one axis and performance score on the other axis. And I just want to point out in the box, and this is something we all intuitively recognize. When you're more than 60 years and you have a performance score of 2, which is not unusual for us to see patients like this who come in sick and you have fever, etc., you're looking at the treatment-related mortality within 30 days, forget about long-term survival, varying from 31 to 82%. And this is a group of patients where clearly none of us are going to be thinking in terms of a conventional 7-3 induction. So there are parameters right up front that we recognize. Additionally, we recognize that as one gets older, and for students out there, I think it's important that you understand that within the young patients, to the majority of patients we see, good risk and intermediate risk are a substantial proportion, while the so-called good risk becomes almost negligible as one crosses 60 years of age, which also has implication today in how we intervene and use some of the newer agents. I'm just going to show you two data sets on this side where my arrow is pointing is our own center data. Green is the median, the age bars in our center, and red is the SEER-based data. They're not really comparable. The SEER data in the US is the population-based registry, and the green bars are single center, tertiary center-based data. But this, I'm sure, is reflective of all the patients that you see in most tertiary centers in the country. The median age in the US is 67 on the registry data. Most of our single center data, the median age is 34 in our center. And in a study of almost 3,484 patients, multi-center, this is an ASH abstract done through the Hematology Cancer Consortium, you can see the median age is 40. So we are seeing younger patients. On the other hand, if you look at the molecular breakdown of patients, there is actually no difference, at least in our own large single center data set, compared to what is published in the literature at the cytogenetic level or at the molecular level. The molecular subtypes, not my objective of this talk to go through this, just to point out the significant heterogeneity of AML and the complexity in terms of the molecular phenotype. And it's also important to recognize that AML is usually oligoclonal at diagnosis. For the most part, current diagnostic tests are only qualitative, they're not quantitative, and they cannot therefore give you the subclonal architecture. And that has significant implications for both MRD and targeted therapy. When you see a patient with FLT3-ITD and you're going to use a targeted therapy, you may want to stop and remember that not every blast will be FLT3-ITD positive. So that targeted therapy will target only a clone if that is the case in a particular patient with AML. Molecular risk stratification in AML, I'm just going to highlight the Blood 2017 ELN guidelines. This is actually older than all the breakthroughs that have come recently. But within that, I think it's important to try and recognize these subsets as quickly as possible because we today have agents that can make a difference. So a stat fish to diagnose co-binding factor leukemia is important because on the meta-analysis, the dramatic improvement on adding gemcitabine in that group. Why is it so important to try and identify the adverse risk group? Because we know the conventional therapy 7-3 or an intensive induction with a TP53, etc., the response rates are so poor and the long-term survival is very poor that you may want to choose to opt not to give a 7-3 to that patient and rather take him for a transplant with a better, less intensive therapy, which we today have. The challenge is, how do we know these parameters before we start? So the question is, how long can you wait? And I'll try and address that question. And these questions become very relevant because, as you are aware, over the last few years, we've had an explosion of new agents that have been approved. And today's talk, we are going to be talking mainly on venetoclax, but we have targeted agents for many of the molecular markers. And venetoclax is especially important both in the older and unfit, but also in the high-risk molecular subtype of patients. So the question comes, when you use these combinations, the therapy is going to look like this, and I'm only going to talk on the hypermethylating agents and venetoclax, but the four arrows that I've pointed out are areas where we already see data which may not have come into recommendations, but we recognize that they are high-level evidence. The co-binding factor leukemias, adding gemcitabine in induction of low dose gives an additional 20% improvement in survival on the meta-analysis. So knowing that upfront before starting treatment is important. The FLT3 data all of you all are aware of. For older and unfit patients, and I would argue even for patients with TP53 and complex cytopenics, the remission induction may be much better off by not using an intensive regimen. So how long can one wait for a molecular diagnosis prior to starting therapy? Because you need to start therapy, you have a patient with AML sitting in front of you. The older data was that you should not wait for more than 4 or 5 days. But looking at this data again, this was an ASH abstract looking at more than 2,220 patients. And basically what the slide is summarizing is that you can wait for 6 to 10 days comfortably with just some supportive care and does not make an impact on the overall long-term survival. Lots of caveats there. This is not Indian data. Our patients may be very different. Our challenges are different. But I think it's reasonable to say that you could probably wait for 5 to 7 days, and most centers should try and work to try and get in their results before that. Akansha has already done a great introduction of BCL2 inhibition. In the context of AML, I just want to say, and just for a background for students out there, the way to try and understand this BCL2 story is that there are some cancer cells that are more addicted to BCL2 than others. And therefore, when you take away the BCL2, they are much more prone to die from the normal apoptotic mechanism. And AML is one of those diseases where BCL2 is highly overexpressed in the AML cells. And more important, it seems to be highly expressed in the leukemia stem cell population, and therefore the potential, so we need to see long-term clinical data for cure in these patients. Let's go to the clinical data that's available with venetoclax. The early single-agent data with venetoclax and relapsed refractory AML was done on about 32 patients. This was the original paper that came in Cancer Discovery by Konopoleva and group Mv Anderson, along with others. They used a dose of 800 milligrams a day. The response was actually not good, with modest overall response rate of just 19%, and the median duration in those that responded was 48 days. None of these patients who are heavily treated and relapsed developed a tumor lysis syndrome. In general, there's a consensus that there is no role as a single agent, either in relapsed refractory or in newly diagnosed patients. So some of you all, if you all, especially juniors, if you feel tempted to kind of just throw this agent at a patient, probably not worth doing that. I'm going to talk about two studies which subsequently looked at the early phase 2 studies. One was from the ECOG group, which is the Courtney-Nirado paper in Lancet Oncology, which I'm sure many of you all are familiar and you all would have seen this data many times over. There's another study which was very similar, which was venetoclax combined with low-dose cytarabine, which is again a multi-center study. The outcomes, the enrollment, the clinical outcomes were very similar. So for the most part, I will be talking only on the ECOG study because essentially that data is replicated in the venetoclax with low-dose cytosine-based data. So let's look at the inclusion criteria, and the objective is not to go through the details of the study design, the inclusion, exclusion criteria, etc., but just to highlight what I think are important. One is it was aged more than 65 years, I think, in the ECOG study, but it was more than 60 years in the other study with venetoclax and low-dose cytosine, but essentially older patients with the definition of unfit. Now, there's been a lot of criticism of what do you think is unfit. I don't think any two hematologists will decide on who is fully unfit in certain situations. None of these patients should have had prior therapy with hypomethylating agents. The WBC count should have been less than 25,000 at diagnosis. Leukapheresis or hydroxyurea was allowed to achieve that count before patients could be enrolled on the study, but there's very limited data on how many actually did get that intervention, and my suspicion is majority of them presented with low counts. And it's also important to remember that AML in the elderly can be slightly different in terms of phenotypic presentation than what you see in a young patient of rapidly galloping AML. The ECOG performance status had to be better than 2. Hawkins function had to be preferred, preserved, and projected life expectancy of at least 12 weeks. I think it's important to stop and look at this data and say that many times when we see patients, they're not going to be like this. Our patients are going to be less fit, they're going to be presenting with rapidly galloping leukemias, they may be presenting with fever, infections, So I think it's not reasonable to think that you're going to achieve the data that is published in these clinical trials in the real world on the next patient that you see. So in terms of dose escalation, again, Akansha has addressed this well. Just the difference in AML is the ramp up is generally more rapid. It's on a daily basis because it's generally tolerated well, and you don't see tumor lysis syndrome, and that was the main reason, I think, for the ramp up in the scale studies with bad experiences early with this drug. So in this early study, the ECOG study, they had a total of 145 patients. The first 45 were just a dose escalation study, and they had 4 cohorts. The overall response rate was 83%, with a CR of 37%. This is incredible data. You must remember that azacitidine, as a single agent, you get a response rate at best about 30%, with a median overall survival less than 10 months. So this data was spectacularly different from just azacitidine alone. The most common adverse effects were gastrointestinal, and even though the study doses went up to 1,200 milligrams, they finally settled for 400 milligrams as the dose for the expansion cohort. Febrile neutropenia was seen in 42%, and grade 3 or more thrombocytopenia was seen in 47%. None of the patients developed clinical tumor lysis syndrome, and these very impressive survival curves in this very older population is strikingly different from what you would expect to see with single agent azacitidine. Now, this is data by Daniel Follia. He's kind of summarized this data, and this is courtesy of a slide of his in Soho 2019. You must also remember that this is a little selective pulling out of data by a person who's sold on this idea and who's invested in the concept of venetoclax with upfront therapy. But it's interesting to see comparisons in elderly and secondary AML, intensive chemo, hypomethylating agent alone, and venetoclax with hypomethylating agent alone. You can clearly see that the data is far superior with venetoclax and hypomethylating agent. 70% remission rate, early death rate of 2%, remission duration is far better, the overall survival is much better, inpatient stay is much lower. So I said all the caveats about the inclusion and enrollment and the difficulty in preparing across the population. Now, who exactly is the fit elderly AML, and what do we do with that? Because if you remember, all these approvals were meant for patients who are older and unfit. Now, what exactly is a fit elderly AML? And that's not very easy to define. So in this analysis of Nature Medicine, Daniel Follier looks back at his own single-center data of patients who went on to get 7-3 or standard of care, who were so-called fit, and he compares a historical comparison, which is red, versus the patients who actually got the venetoclax with hypomethylating agents, and shows significantly better survival in this retrospective analysis. Obviously, there are limitations, as with any other retrospective analysis. It's single center, small numbers, there could be enrollment bias, but there is promise over there in elderly patients in general, not just unfit elderly patients. Now, the next question that we want to know in the elderly, do all molecular subgroups respond the same to therapy with venetoclax in AML? And the answer is no. And there's an abstract in EHA in 2018 which looked at this. And clearly, disappointingly, the TP53 response rates are quite high, but the long-term survival doesn't seem to be so good. While the NPM1 and the spliceosome mutation did very well in this elderly group of patients. So what about as a bridge to transplants? Very limited data. This is something I would certainly be interested in, even in our young patients who are unfit or have high-risk adverse cytogenetics, where I would like to induce them and take them to transplant, if possible, with MRD negative or at least in complete remission. And in this very small study, just 31 of 304 patients actually went on to get a transplant. These are elderly patients, remember that. And within that, the survival was promising. 68% are alive at 12 months post-transplant in an elderly cohort of patients. But please note the serious selection bias in the number of patients that actually went for the transplant. So there are a lot of selection biases in these transplant data, especially when you're looking at elderly populations. So the people who actually finally end up with transplant is really a selected subset. So moving away from the elderly, what about using these patients in young patients? Like most of our patients are young patients that you and me will see in the clinic. There's very limited data. Many centers in India, I know, are upfront using this therapy based on very little parameters, just a gut feeling that they won't tolerate 7-3, etc. So this is a phase 1b/2 study looking at FLAG, IDA plus venetoclax in patients with newly diagnosed or relapsed refractory AML. This presented as an abstract, but the newly diagnosed cohort is actually continuing to enroll. I'm not going to go through this data in detail, except to say that the initial escalation doses with cytosine and cytarabine and venetoclax this was a phase 1b/2 trial, so they were looking at dose escalation and consolidation with fludarabine and cytarabine plus venetoclax at 400 milligrams. And the newly diagnosed patients, young, fit patients, the survivals are incredibly good. They're absolutely flat over there. Extremely small follow-up, extremely small study. The enrollment is continuing to go, but it is potentially possible that we may be seeing major shifts in the way we are going to treat even our young patients with AML. Note, though I've not shown this data, there's a very dismal outcome in patients who have relapsed, who have already received azacitidine and venetoclax previously. The median overall survival is only 2.4 months on using any. I'll sum up with a few practical strategies, and this is actually in Blood 2020. It's how I treat, and I'll talk a little bit about it. It's slightly different from what people have said. The ramped up dose is going up to 400 milligrams with azacitidine 75 milligrams. Significant dose reduction possible with CYP3A4, but as Uday correctly pointed out, caution, there's not enough long-term data. There is two groups of thought. One is that you can safely reduce the dose to 100 milligrams of venetoclax with posaconazole. The other would cite a little bit more caution, especially in induction. There's been no significant TLS. Oral administration is recommended 30 minutes after the meal with a glass of water. Hospitalization, if severe, is prolonged neutropenia. How do you assess these patients post-induction? Akansha kind of touched on this. You do day 28 marrow. If there's persistent blasts, you continue treatment without any delay. If there is cytopenia with bone marrow blast less than 5%, and that's less than 500 and less than 50,000 platelets, you hold treatment, give GCSF defer the next cycle by 7 to 14 days. And also in the context of AML, once you reach a stable dose, the option is to try and reduce the duration rather than the dose. So you may reduce it to 21 days out of 28 days and then 14 days out of 28 days before you actually touch on the dose that you finally choose to give, whether it's 100 or 200 milligrams with or without posaconazole. Which of our uncooked patients would we give azacitidine and venetoclax? This is a very important question which you and me grapple with every day. And in multi-consultant departments, I can imagine you will always have the discussion, should A get 7-3 or should he get azacitidine venetoclax? There is no good answer. There are scoring systems out there that predict mortality. And this kind of data has the problem that they are not relevant in India because we really don't have data that is validated in our center. This is a crowded slide. I won't go through that. This is an exercise we did through HCC through multiple centers. Using artificial intelligence, we've developed a score that can predict mortality. And this is something we plan to continue to do on a prospective study. It's called HCC PRISM. Multiple centers have planned to enroll patients. Some of them are awaiting IRB approvals. The study is led by Smita and Rajan. I encourage all of you all to join in these efforts because we really need region-specific data to guide us in the way we approach these problems. Thank you for your attention.
Thank you, Professor Vikram. We now go to the last talk. Okay, so can you see my slide and hear me full screen?
Yes, that's right.
Thank you. So, Kalpesh informs me that we've got 550 plus audience who have logged in. That's fantastic. And all the speakers have done a tremendous job. You must be hungry, waiting for your lunch, but to bear with me for one last subject. And that is now use of venetoclax in myeloma. Apoptosis. Sir John Sulston, a British biologist, winner of Nobel Prize in Medicine in 2002 for his work in apoptosis. What is apoptosis? Apoptosis begins when the nucleus of the cell begins to shrink. After the shrinking, the plasma membrane blebs and folds around different organelles. The blebs content and move away from one another. And this is pictorial presentation of what I spoke, an intact cell. Remember the clinical sign of ptosis, which means falling eyelid. Apoptosis is apoptosis, a Greek word, and it means falling off of leaves from trees. John Kerr and his colleagues reported the phenomenon of programmed cell death, and they considered apoptosis as the most appropriate one. An average adult human loses around 60 billion cells each day due to apoptosis. And similarly, an average human child between the age of 8 and 14 loses about 30 billion cells each day due to apoptosis. And necrosis. It's a traumatic cell. This is what you see on the left upper and the right upper, how the webs are undergoing apoptosis. Coming to myeloma, the most important prognostic factor in myeloma are the genetic factors. And in clinics, we test these factors by FISH study and risk stratify our patient by looking at, for example, 17p minus, T414, 13 monosomy, hyperdiploidy, and so on. In myeloma, we did not and we do not have a targeted therapy. The proteasome inhibitors, the IMiDs, the alkylating agents, and the steroids are used irrespective of what the genotype is. The genetics of myeloma, therefore, in practice is purely a prognostic tool and has very little bearing on the treatment. This is chromosome 11, and this chromosome 11 has, if you look at the arrow, the CCND1 gene. And that's chromosome 14. And if you once again look at it, it has got immunoglobulin heavy chain gene. And that's the condition we are talking about, T1114 translocation, which allows the CCND1 gene to fuse with immunoglobulin heavy chain gene. And that's what is shown in the karyotyping here and on the fish on the right side. In multiple myeloma, 1114 is a commonest translocation, present in almost 15 to 20% of de novo patients. As against this, 414 that we keep talking occurs in 15%, 1416 in 2 to 5%, and 1420 only in 1 to 2%. In the era of proteasome inhibitors and IMiDs, the novel agents, myeloma with T1114 is classified as intermediate risk. The T1114 myeloma is a distinct entity, both biologically and clinically. Morphologically, the plasma cells are lymphoplasmacytoid in their morphology. That is, there's a large nucleus, there's a scanty cytoplasm. These patients have more bone disease. Prevalence of non-secretory multiple myeloma is higher with T1114, and some of these patients, if you investigate, could be even IgE. CD20 is heavily expressed, and cyclin D1, of course, is expressed. Most important for today's talk is that the BCL2 is overexpressed. At the same time, there is a lower expression of other two anti-apoptotic proteins, the MCL1 and the BCL-XL. And that's why there is a golden opportunity, first time in the history of myeloma treatment, of offering a targeted treatment using BCL2 inhibitors. That's venetoclax. Venetoclax is a new wave in hemato-oncology, which you witnessed for last 1.5 hours. Venetoclax CLL, venetoclax AML, and now venetoclax multiple myeloma. What you see on the left side is the BCL2 as a pro-apoptotic protein and allows the cancer cell to survive. When you use venetoclax, which is an anti-BCL2, the cancer cell dies because of activation of caspases. Venetoclax is selective inhibitor of BCL2. It has been shown to have single agent clinical activity in myeloma, even in relapse setting, suggesting how dependent a myeloma cell is on BCL2, especially when there is a translocation 1114. However, when it does not inhibit MCL1, it does not inhibit BCL-XL. So looking at the picture again, what you see in the colored circles are our anti-apoptotic proteins, the BCL2, the MCL, and the BCL-XL. BCL2 is blocked by venetoclax. And to take you further with my talk, I would like to introduce two more agents, bortezomib and dexamethasone, that we routinely use in our practice of myeloma. Bortezomib inhibits MCL1, and dexamethasone increases the levels of BIM. And what you see in all these gray circles are the pro-apoptotic proteins. Imagine a situation when you like to give venetoclax with dex or venetoclax with bote and dex. You got a triple attack on the myeloma cell. Relapse refractory myeloma cells do have an overexpression of MCL1, and therefore you need to down-regulate it, and therefore it's wonderful policy to combine venetoclax with bortezomib. As I mentioned, dexamethasone increases the expression of BIM, which is a pro-apoptotic protein, so it's another great opportunity to combine a PI with a bortezomib or carfilzomib and dex with ven and have a synergistic combination with best results. I'd like to show you 3 studies. Starting with Shaji Kumar, published in 2017, predominantly a monotherapy using venetoclax, and in some patients, dexamethasone was added. The sample size was 66 patients, and this was a phase 1 study. In France, Morio and his group same year published a phase 1b study where all the patients got venetoclax in combination with bortezomib and dex. Once again, the number were 66 patients. A year later, Costa and their group in 2018 published a data of 42 patients, which was phase 2 study, where bote was replaced with carfilzomib, the best and the most potent PI. So ven, carfil and dex. If you look at what was the type of patients where these trials were done, the line of therapies these patients were already exposed to were a median of 5, 3 and 2. And some of these had received up to 7 lines of therapy, 13 lines of therapy and 3 lines of therapy. If you look at the percentage of patients who had T1114 translocation, in Shaji's group it was almost half of the patients. In French study it was 14%, and in Costa study it was 19%. And now this is the most important part, the right column. Let's look at the responses, and we are looking at 2 types of responses. Overall responses, which includes patients having T1114 as well as not having 1114. In Shaji's group, once there was 1114, which was there in 46% of patients, the responses were 40%. And in the rest of the group, it was actually only 6%, as a result of which the overall response was 21%. You add one more compound, bote, and you add dexamethasone. This triple combination in the French study shows you an overall response of 67%, and selectively in 1114 translocation, 78%. These results are almost double of venetoclax monotherapy or venetoclax with dex. And then you come to Costa study, where bote is replaced by the most potent carfil. The overall response goes up from 67 to 79%. And look at this. There was no patient who had 1114 translocation and who did not have response. The responses were 100%. This is Shaji's publication in Blood in 2017, the phase 1 trial of efficacy of venetoclax as targeted therapy in relapse refractory T1114 myeloma. And the conclusion was the monotherapy at the daily dose, which was escalated from 100 to 1200 mg, has an excellent acceptable safety profile in relapse refractory myeloma patients. It demonstrated anti-myeloma activity in relapse setting. And these were the results. And I want you to concentrate not on the left side, but in the center and the right side. If there was no 1114 translocation, the success was just 6%. While if there is 1114 translocation, the overall response by venetoclax plus minus dex was 40%. So this is a real targeted therapy. When you have 1114, the response is huge with compared to when it is not there. And if you look at the time to progression, the median time to progression with 11-14 was 6.5 months, with median duration of response being 9.7 months. While if there was no T11-14, it was just 1.9 months. That's the French study by Philippe Morio, promising efficacy and acceptable safety of ven with Bolte and dexamethasone in relapse setting. And the conclusion was that this appears to be safe and efficacious, and that's a novel therapeutic approach. And that's the third study of carfilzomib, venetoclax, and dexamethasone, finally published in 2020 in British Journal of Hematology. And you look at this central bar, these are the patients having 11-14 translocation, overall response rate of 100%, with CR of 20% and VGPR of 80%. That means when you combine ven with carfil and dex, you got 100% responses which are VGPR or above. And if you didn't have 11-14, the response was 0. This is Bellamy phase 3 study presented by Shaji in last ASH meeting. Venetoclax versus placebo in combination with bortezomib and dexamethasone. And all of you, I'm sure, are aware that FDA had a temporary halt to this particular study because there were more deaths in the venetoclax group. However, going deeply into the study, it was realized that these more deaths in the venetoclax group were in patients who did not have 11-14 translocation, and they also had simultaneous progression of the disease. And when you separately looked at the patients who had 11-14 translocation, then those deaths were nullified between the placebo group and the venetoclax group. I will like now to point out certain ongoing clinical trials. And these are very fascinating studies because they use best of the products in combination with ven. So you've got venetoclax with carfilzomib and dexamethasone in relapse setting. And you've got now ven with DARA in patients who have 11-14. You've got a quadruplet combination of ven, DARA, Bolte, and dex in patients who have 11-14. And then you've got a phase 3 study of comparing ven-dex with pom-dex in patients who have specifically 11-14. We don't have results of this trial, and the whole world is looking at this to know the optimum combination with the best results. We also have an all-oral ven-based combination, and that is venetoclax with ixazomib and dex. And this is currently being examined in phase 2 clinical trial. This is simple home therapy, 3 important drugs combined together at home. What about venetoclax dosing for myeloma? In most of the study, ven was straight started in the dose of 300 to 400 for a week and then titrated to 800 mg depending upon the tolerance. And the goal was to reach the dose of 800. Even the doses of 1200 per day have been used as Shaji used it. No tumor lysis syndrome has ever been reported in patients of myeloma, and hence the weekly dose ramp-up start is not required for multiple myeloma. Looking at the safety profile was acceptable. 8 large tablets of venetoclax. Akanksha showed you the size of the tablets of 100 mg. For 800 mg, you're going to swallow 8 large tablets of venetoclax at a time. And this issue needs to be sorted out by AbbVie. Hematological toxicity was as expected in pre-treated patients with multiple myeloma. GI toxicities, and Akanksha has elaborated that nausea, vomiting, and weight loss were frequent, and also fatigue was common. Infections. Venetoclax targets plasma cells, not only malignant but also normal, as a result of which almost all patients develop hypogammaglobulinemia. So you depress the humoral immunity. Myeloma per se and the earlier lines of treatment result into significantly impaired cellular immunity. So you have got a significantly immunocompromised myeloma patient. prophylactic antibiotics, and prophylactic IVIG, especially to patients where IgG levels have gone below 400, could ameliorate the increased risk of infection. This is then the real world data on safety and efficacy of venetoclax-based trial in relapse setting published from Cleveland in British Journal of Hematology. Changing gears, I would like to talk to you about two rare conditions. One is primary plasma cell leukemia. It is rare. It's the most aggressive form of multiple myeloma ever described. Very poor survival, and we don't have a good treatment. What is interesting is 60% of primary PCL have 11-14 translocation and very high BCL2 expression. Venetoclax therefore appears to be a useful drug in this setting, and occasional patients with Mrd negativity have been described. And this is a publication in AGH in October last year. Combination of Ven with Dara with Dex in treatment of refractory plasma cell leukemia. Once again, three of the best anti-myeloma agents. And this is again published in AGH. Single agent venetoclax inducing Mrd negativity in a relapsed primary plasma cell leukemia. So friends, plasma cell leukemia, test for 11-14, 60% chance will be positive. Don't forget venetoclax. This is a case of plasma cell leukemia published in the literature and venetoclax. VDT-based started therapy and then venetoclax with daratumumab with dexamethasone. The lambda light chain normalizing, the creatinine coming down. The last condition I want to discuss is AL amyloidosis. Those of you who tuned in yesterday heard this data in the evening. We had the webinar on AL amyloidosis. Approximately 50% of AL amyloidosis have 11-14 translocation. So 20% of myeloma, 50% of amyloid, and 60% of primary plasma cell leukemia have this translocation, which we want to target at. When Ven is added to VCD, it converted PR into CR. Unlike myeloma, amyloid patients have damaged organs, that is heart and even kidney and liver. And therefore, one has to look at the organ function profile when you are using a new drug in this situation. This is publication venetoclax for treatment of 11-14 AL amyloidosis. And that's venetoclax induced complete response in a patient of amyloidosis where there was a plateau on CyBOR-D. And this is venetoclax in amyloidosis, CyBOR-D to begin with, venetoclax, Borte, and dexamethasone to be followed, and then venetoclax, dexamethasone. And you can see what happens to the light chains. I'm going to close with two cases to be shown to you in our personal experience. The case one is Mrs. SK, 65 years from Mumbai, first seen in 2014, ISS3 kappa light chain with normal karyotyping. She received 5 lines of therapies: VTD, autologous transplant, VRD, KRD, and DPD. And then presented suddenly with drowsiness, almost unconscious, with calcium levels of 18. And this was due to relapse of her myeloma. T1114 was picked up when we did FISH at this time, and that excited us to put her on Ven-KD combination. 6 months later, she has complete response. So this was Ven with carfilzomib with dexamethasone in a person who was already exposed to carfilzomib and dexamethasone. My second case is PR, 48-year-old young man from Delhi, first seen in 2016, ISS3 IgG kappa, and had 11-14 translocation. He received VRD followed by transplant, relapsed 30 months later, received KD as the third line therapy, and then DPD as the fourth line therapy. Inadequate response and presence of 11-14 positivity made us start Ven with Carfil with Dex in October last year. He achieved VGPR after 4 cycles, and now he has been subjected to second autologous transplant last month. I conclude my talk by saying that myeloma patients must be tested for 11-14 by fish, not only at the baseline, which you may be doing, but in the era of venetoclax at each relapse, because 11-14 translocation may be absent in de novo and can be an acquired secondary abnormality. We do that in CLL, we don't do that in myeloma. This kind of targeted therapy will avoid toxicity associated with so-called standard drug therapy, which are ineffective and also decrease the cost. In my mind, when KD is an extremely promising combination, and as you saw in Costa study, 100% responses, this is a perfect biomarker. The T1114 is a perfect first biomarker for a first targeted therapy in myeloma. However, we definitely need more clinical studies and longer follow-up before we can adopt venetoclax widely. We need to look at what is the future agenda. We need to look at the safety, efficacy, and the best optimal combination of venetoclax in a galaxy of myeloma patients. We also need to look at the venetoclax as an upfront targeted agent for newly diagnosed myeloma patients with those 15-20% 11-14 positivity. We need to find out who are those patients who are not responding to ven despite 11-14 translocation. Early studies have suggested that myeloma patients who best respond to venetoclax are those with low plasma cell S phase and lacking 414 and 1Q gain. In vitro functional testing to assess the expression of BCL2, expression of MCL1, and expression of BCL-XL may help us in predicting the response. Well, thank you so much for giving me this opportunity to speak to you. I again remind you, coming Saturday, we have sickle cell disease webinar with international speaker Zuli Cantor. This is in the evening. And then the next Sunday, we have the symposium on ITP at our standard 11:30 a.m. with a galaxy of speakers from India. And you will get the information to log in. And now we come to the question and answer session of the day. So we have a couple of questions and I will address them to individual speaker. Lalit Mohan Sharma has asked a question to Dr. Seema. Dr. Seema, very good overview. Can you comment on low dose Ibrutinib after 2 or 3 months of full dose Ibrutinib? Dr. Seema.
So, as far as the dose reduction is concerned, there is no data which shows that dose reduction should be done after once you start with the full dose, and then if you have a good response, reducing dose. We do not have actually data which encourage us to do that to avoid AIDS. But in real world, so many people are doing like that because of the comorbidities and associated concurrent drug and to reduce adverse events. But there is no actually data which support.
Thank you, Seema. I may just quote there the Netherlands study of Dutch people, which is just a one-center study, where what they did was all those patients who could not take full dose because of either atrial fibrillation or some bleeding tendency or any other reason, they went on analyzing those patients. And at the end of about 2 years, at least they have presented this data that the efficacy was similar to full dose. And in fact, in the Western world, that made J&J remove the tablet of 140 and 320 so that every patient is kept on 420. The next question is from Dr. Santosh. How to manage when atrial fibrillation occurs? Can we restart Ibrutinib afterwards? Which anticoagulation to use and how long? Seema?
So, as far as atrial fibrillation is concerned, it depends on what is the grade of atrial fibrillation, like whether it is a symptomatic or just asymptomatic, no drop of BP and no syncope or dyspnea or exertion. So it all depends. We have to take in consultation of the cardiologist whether they want to intervene and control the rate of heart with the antiarrhythmic. So if antiarrhythmics are advised, then definitely you need to adjust the dose of Ibrutinib, because many of them, like Cardaron or Verapamine, they are moderate inhibitors, and they might increase the activity of the Ibrutinib. So it has to be reduced. And then secondly, we have to evaluate whether these patients are at the risk of stroke or not. So if risk of stroke is like there is a scoring system and it shows its risk is 1 or more than 2 and requiring anticoagulation, then in that situation, Apexaban has been recommended, can be added with the Ibrutinib in a dose of 2.5 or 5 milligram BD. And second option is Dabigatran. 150 BD is the recommended dose, but you can reduce it to 110 BD. As far as antiplatelet drugs are concerned, single antiplatelet drug administration with Ibrutinib is okay, but when it comes to double or triple antiplatelet drug addition, you need to, in triple definitely you need to hold the Ibrutinib. Once this atrial fibrillation episode is under control, you can restart with the Ibrutinib, and as has been mentioned in the data, its occurrence usually reduces over a period of time. And the risk of having atrial fibrillation is most when patients are more than 65 years of age and if they have a earlier episode of AF.
Thank you, Seema. The next question is from Dr. Lalit Mohan Sharma. It's about what is the longest duration of Ibrutinib in real life clinical practice, and he says that Dr. Agarwal has to answer this.
Yes, because you have a greater experience of using these drugs. Yes,
if Lalit, you are asking about my personal, it is 3 years, and internationally it is almost 7 years if you include the patients who were a part of the trial. Next question is from there is a request to start my video. So I have started my video. So next question is from Jakiyamani. In elderly patient with comorbidity with hypertension, IHD, CKD, can we use Ibrutinib in the usual dose? And if not, then what should be the dose and what should be the duration? Seema? Seema, you are bombarded with questions.
So, as such, hypertension or CKD is not a contraindication for Ibrutinib, and no dose adjustment has been recommended. In IHD, you have to see whether you are giving one antiplatelet drug or doublet or triplet, and accordingly then we have to manage depending upon the bleeding complications.
Okay. Next question is again to Dr. Seema from Shilpi Saxena. Ma'am, can an incidentally diagnosed asymptomatic CLL be started on Ibrutinib, and what is the minimum absolute indication to start Ibrutinib?
So minimum absolute indication is just like any other for any other therapies. Like we don't start treatment at stage 0, and there are criteria to indicate whether patient can be started on therapy or not. There has to be a progression, like for any other therapy. Starting therapy, we always see whether lymphocyte doubling count is rapid and causing more than double within 6 months or not. There is a progressive increase in organs or not, which is causing compressive symptoms, lymphadenopathy, platelet less than 10,000, hemoglobin less than 10. So asymptomatic stage 0, no role of Ibrutinib.
Right. So I may just once again add that there is a work going on in Germany, and what they are trying to do is to look at patients who do not fulfill the criteria of treatment, give them Ibrutinib and see whether it changed the natural history of the disease. Now the world is not convinced that whatever is the outcome of this data, whether one would ever give a drug like Ibrutinib, which if you look at in the long term is reasonably toxic.
The similar data was there on FCR also, whether we can decrease the, means whether we can avoid the progression, but it didn't show any evidence to start with at stage.
Right. So according to what I see, there are no more questions. Kalpesh, is there anything else? I don't see any more questions. There is only yes, Kalpesh.
No question.
No more questions. Only in the chat box there is a remark from Uday. It's a compliment to Mice Ideas. Great job done, Mice Ideas. The live relay is fantastic. Students are enjoying. Thanks to Professor Agarwal, Vikram, Mathews, Seema Madam, and Akanksha for great presentations. So that's from Uday to everybody. And Uday, you also did a great job. On my behalf, I'm grateful to our sponsors, Adley Lab, Mr. Ashutosh Sharma. I'm thankful to Mice Ideas for a smooth conduction of these activities, and Kalpesh, I keep bothering for the whole week so that the end result is fantastic. There's not a single day when I don't bother Kalpesh. And I'm grateful to the faculty who readily agreed to work on this presentation, spare their Sunday afternoon, whatever said and done, even if you are at home 24 hours a day. Sunday is for the family, but you are here for the academics. Thank you so much. Over to Ashutosh Sharma for the vote of thanks. Ashutosh, are you there? Ashutosh,
Yeah.
Yes. Please.
Thank you, sir. So we are now on the verge of closing today's event. I must thank our elite speakers, Dr. Seema, Dr. Akanksha, Dr. Uday, and Dr. Vikram Mathews for their wonderful presentation. I am indeed grateful to you, sir, for your continuous academic feast. Without such initiative, this would have not become possible to conduct such a series of academic activity. So thank you to Dr. Mv Agarwal for the same. I am thankful to all the participants for sharing your valuable time this Sunday afternoon and making the event a success. Just want to share with you that we have already sent digital certificates to all the participants who attended the last Sunday's webinar, which was conducted on 17th. And for this webinar, we'll be sending the certificates tomorrow evening. I am thankful to Mice Ideas for flawless execution of the program. Lastly, I am thankful to Team Adley for coordinating with all India doctors and follow-ups. And as this today's webinar was on novel agents in hematology, so I am glad to share with you that Adley Oncology is also ready with Ibrutinib. The only thing is that we are waiting for the patent to get expired to launch the product in India. Thank you all so very much, and looking forward to see you next Saturday as well as Sunday. Thank you so much, sir.
Thanks to everybody. Have a great lunch.
Bye.
Thank you, sir.
Bye-bye. Bye-bye.
Thank you, sir.
Leaving the meeting.